Good afternoon and welcome to United TV. My name is Kemal Erkan. Today is April 25th, 2025. And on our Bariatric Friday, we are going to actually have a different discussion, related but different. We are going to discuss general surgery, and I'm going to actually go into the details why we are doing this today. As CHRIAS and American Surgery Center, outside of bariatric procedures, we do a lot of general surgery. But from our accountable care organization side, we have so many follow-ups we have to do. Orders are coming through our primary care and some of the other specialties, and then how we follow up and what some of our findings are. And my goal today is to make sure that we provide good education for our patients and better understanding of especially like hernia repairs, gallbladder, diverticulitis, appendicitis, and maybe some other surgeries, general surgery types that we are going to be discussing. Now, of course, this is a channel that's on the clinical side. I only have licensed physicians, providers who are with me, and today Dr. Gail Wynn is going to join me. Dr. Wynn, how are you doing?
Good, thanks. Happy to be here.
Well, thank you for joining us. And we wanted to actually have a good understanding of a couple of these general surgery, which are the most common ones. But before we get into that, if we can kind of define what general surgery is today in today's practices.
Sure. General surgery is basically all the surgeries except for things like GYN surgery and urology. So it's anything inside the abdomen other than kidneys, uterus. And then general surgeons also do things like vascular surgery, minor procedures like lumps and bumps, breast surgery. But in this area here in Northern Delaware, because we are a tertiary kind of center, most of the general surgeons are kind of specialized in the abdomen and lumps and bumps, and then there's separate breast surgeons, there's separate vascular surgeons, and then there's also chest surgeons.
So I guess for our specialty, like someone like yourself, although one of your expertise is bariatric surgery, you probably do more or similar amount of general surgery cases, just like any other general surgeon. Would that be true?
Correct. I do about 50% general surgery, 50% bariatric surgery.
Mm-hmm. So now I guess one of the most common ones is hernia, and hernia has different types of hernia. And as I was going through everything that we do with CHRIAS and in the surgery center, I had to learn a lot in these. It's not just the terms that I learned, but also I learned exactly what needs to be done and how it's being done. Scrubbing several times with you guys was an amazing experience. So now, if we were to kind of understand what hernia is, how do we determine the hernia surgery, and when do you decide to do that surgery, in what conditions?
Sure. So there's different types of hernias, number one, and a hernia is basically a hole in the muscle. And so what happens is something from the inside of the abdomen is protruding through this hole. Mm-hmm. So there's different types of hernias. We'll start from the top. One is hiatal hernia, and that's a hernia that goes through the hole of the diaphragm. So it usually goes to the hole where the esophagus comes through into the abdomen to connect with your stomach. And hiatal hernia, the reason you would operate on that is if you have intractable reflux, like acid reflux, that just is not getting better with medications. Sometimes people have ulcers that bleed because their stomach is getting strangulated from that hiatal hernia. And other times it's just the stomach is flipped up on itself and it's causing an obstruction. Mm-hmm. And so we basically have to operate on that so that people can actually eat again, swallow, and maintain their weight and nutrition. Then we could go to umbilical hernias. Umbilical hernias is hernias in the belly button. Mm-hmm. And usually it's something that might have been there for a long time, but as you age, as you move around more, lift more, push, pull, that hole gets bigger and now something sticks out. For most hernias, like umbilical hernias, groin hernias, ventral hernias, they don't need surgery unless they start becoming symptomatic. So, meaning they start causing you pain, discomfort, or if it gets stuck out
Hmm.
and then you have to, you're having pain and discomfort, or it turns red, that's a surgical emergency. A ventral hernia is basically a hernia that is through the abdominal wall, and it could be anywhere in the abdominal wall. The incisional hernia is basically a hernia through a previous surgical incision.
Hmm.
And then there's inguinal hernias, which is hernias in the groins. And there's different kinds of hernias there. There's a femoral hernia that goes through where the blood vessel, the femoral artery, femoral vein goes through, called a femoral hernia. Inguinal hernia is just mostly in the inguinal canal. And then there's something called an obturator hernia, which kind of occurs a little bit more like under the leg. But all these hernias, if you just have a lump and a protrusion, we don't worry too much about that.
Hmm.
We do check it out to make sure it's not like a mass, a cancer. Sometimes it could be something like a lipoma. But if it's a true hernia, we don't operate on it unless it's causing you pain, discomfort, or it's causing like a lot of redness and irritation.
Sure. I think one of the most common problem that I see is the delay from the patient side when they actually want to come to the general surgeon to see the resolution for these. I see, and one of the reasons that we wanted to do this session is when we are doing the order follow-ups from the accountable care organization side, we see where the patient actually delays these procedures, and there's different reasons for each of them. But what are the typical issues when we delay the hernia, as this one can be done in the elective setting versus in the emergency setting? What actually, what are some of the reasons and the end results of delaying these procedures?
Sure. So when you do something electively, that means like kind of like at your own time. And we want to fix these hernias when they're not that symptomatic. So when you first start having pain and discomfort, that's when you come see us right away. The main reason why is sometimes you could do something like lift something, cough, sneeze, have a bowel movement, and you're pushing real hard. And all of a sudden now the hernia sticks out, it's stuck, it's causing a lot of pain, sometimes a bowel obstruction because a piece of small bowel can get stuck in there. It becomes red, sore. It can make you pretty sick sometimes. So you want to fix it when it's starting to become symptomatic, not fully an emergency. Once it becomes an emergency, it's a lot harder to do the surgery. It's more inflamed. The chance of putting a mesh in to fix the hernia properly is much less, so it may require a second surgery in the future. Higher chance of recurrence of the hernia if you can't put a mesh in the first time. And then there's a higher risk of things like you have to take out small bowel or colon or whatever is stuck in there, and a prolonged hospital stay. Most of these hernia surgeries, they can be done outpatient. So you come in, you get it done, you go home 1 to 2 hours after surgery.
And delaying can make this extremely dangerous for the patients.
Absolutely.
And also the other thing is that costly. So
Yeah.
if it's an elective procedure, how that's being done, and what may be needed for that procedure versus when it's done in the emergency setting, the cost is going to start from the emergency room. And in some cases, those patients, most likely they need to stay overnight, maybe more than one night. So all that's going to actually increase the cost for something that can be done, let's say like for 1x, now it's going to become 3x. So it will be an extremely costly procedure and painful
Yeah.
at the same
It could
time.
also be a bigger surgery too, because when it's done electively, we could do it laparoscopically through small incisions. If it's done emergently, sometimes you can't do it that way. You have a bigger incision, it's more involved. You might be taking out body parts that are stuck in the hernia, and then it's a longer recovery. It could be days versus just, a 1 hour surgery.
Anyone is at more risk from their sex or the age standpoint? Like I know, like we are going to talk about like other procedures. In some cases, women or men, they may be higher risk for hernia. Is that the case?
So I think as far as hernias are concerned, it's higher risk and more common in people that are overweight. And then the one thing that you want is, when someone is overweight that comes in with a hernia, you want them ideally to lose some weight if you can in the elective setting. If someone is a smoker, it basically is almost like 100% chance that hernia is going to come back. So you want them to stop smoking. When you're doing things more electively, you could have them start protein right away and optimize their nutrition to help them heal faster and better. As far as is it more common in women versus men, inguinal hernias are more common in men than women. Femoral hernias are more common in older women than men. Paraesophageal hiatal hernias, which are hiatal hernias where the stomach flips up on itself, it's more common in older women than it is in men.
I see. Now, we can actually go to the gallbladder. So, gallbladder is one of the procedures that when we used to have our surgeons for emergency group, we came up with two different policies. One was for gallbladder, the other one was appendix. And this is where I kind of learned a lot of things between different procedures and how the symptoms can actually change. I can actually diagnose a lot of people with gallbladder. So now, what is a gallbladder and early symptoms and the risk of gallbladder? If you can actually just give us the background on the procedure.
Sure. A gallbladder is actually an organ that sits under your liver. The main purpose of the gallbladder is to store bile. So bile is created in your liver, and because you're not eating constantly, the bile is used actually to help you digest your fats. So when it's not being used because you're not eating, it kind of goes into your gallbladder, is stored there until you eat. Once you eat, there's hormones that cause the gallbladder to squeeze that bile out to help you digest your foods. So sometimes what happens is gallstones occur and they form in your gallbladder. Usually occurs in women over 40 because of hormones. If you have a really bad high-fat diet, it's more likely to occur as well. So that's the Great American Diet. And so what happens is once you form stones, those stones can lodge in the duct that empties the gallbladder. And when it does and the gallbladder squeezes against it, it causes pain and discomfort. And then the bile is kind of sitting there stagnant, so it can actually get infected and cause an infection of the gallbladder. When that happens, we call that cholecystitis, which is inflammation of the gallbladder. So when someone has a gallbladder attack, it usually presents itself as abdominal pain, either up high, kind of just under the breastbone, sometimes on the right side of their abdomen, sometimes on the left side of their abdomen, sometimes on the right flank. And it's often associated with eating, especially eating something that has fatty food, a lot of fat in it. And then in addition to that, sometimes you can have nausea, vomiting, indigestion along with it. Once you first start having symptoms, you want to see a surgeon to get a workup and get your gallbladder out. Because if you wait too long, then your gallbladder could possibly get very inflamed, thickened. And then once again, it's an emergency surgery. It's harder to do. There's bigger risk when your gallbladder is very inflamed. There's injury to your liver, there's injury to the bile ducts, things can get really stuck.
And from the physical feeling of it, the pain, would that be on the
right side?
on the right side?
Usually,
Right,
it's usually sharp. Some people say it's like the worst pain they've ever felt.
like the upper quadrant, right?
Yep, right upper quadrant, yep.
So,
Or sometimes right flank. And then it could radiate to your chest, could radiate down in your lower abdomen, but mostly it's right side, sometimes left side.
so when people delay this procedure, what type of risk are we talking about here?
So when you delay your procedure, sometimes the gallstone that's in your gallbladder can go down in your bile duct and block it up, and that can make you turn yellow. We call that jaundice. It could cause an infection in the bile duct, which we call cholangitis, which can make you really sick. It could lodge in your pancreatic duct, which could also make you very sick, gives you even worse abdominal pain, and it could give you pancreatitis. And so when you have a bad gallbladder, when you start having the symptoms, even just the first symptom, it's time to get the gallbladder out.
So I guess trying to understand the patient mentality when the surgeon tells me, "Hey, you need to have a surgery." Well, let's say they didn't have this full trust, and then they went to a second general surgeon and they got second opinion, and it's the same decision. Now, do they think this can get better? Because there are a lot of junk information out there on the internet. So it will say, here's your magical food that you need to eat to get rid of the gallbladder or the hernia or the Alzheimer. So, and then we believe those things, by the way. Like, selectively, I may be one of them. So we find solutions to cure those issues on our own. Are there any reasons for patients to believe that this could be fixed on their own by eating XYZ versus doing certain things?
There's really no cure for gallstones and gallbladder problems other than getting your gallbladder out. I did have patients tell me like they read it on Google that if they drank all this vinegar, it would purge their gallbladder of their gallstones. And they still came back to see me because it didn't work. They were still having pain. And they kind of had really bad reflux because they burned their esophagus from all this vinegar water. So there are a lot of misinformation out there that you could purge these gallstones, but it's not like kidney stones. You can't blast them, you can't laser them, you can't pass them. You really just have to get your gallbladder out to get it out.
And one of gallbladder is one of the most common
Yes.
emergency surgery, right? So appendix and gallbladder, those two. Now, what I want people to understand is when it's not done in elective settings, let's say if the gallbladder is identified, diagnosed, and then you give them 2 or 3 weeks, or let's say someone who's diagnosed in end of March, and let's say that person is a teacher and wants to wait until end of May, I can see if it's not severe, I can see them delaying, but still schedule it. Versus if it's not done, this is what happens. So many people don't know the hospital settings, but you and I, we know this very well. But we also know something else in the hospital setting where not every time of the day is same in the hospital, right? So, for example, one of the big hospitals in, Christiana Hospital, so if they have 20 ORs available for emergency surgeries or elective surgeries between 7 a.m. and 5 p.m., after 5 p.m., that goes down to 10. And after 11, it goes down to 2 OR. So if you have this surgery, if this emergency at 5 p.m., now you go to the ED. From the time to ED to the time to the OR, it can take, I believe its average is 8 to 9 hours. This is also true for appendix. I mean, you remember those
It's actually longer than that. But
right? It can be even longer than that. And again, this becomes like a life-threatening problem at that point. So that's why doing this session and then kind of making this available for those who are delaying. Again, like if there's some scheduling issue, and then if it's not as severe, then you can kind of maybe sit on it a couple of weeks or maybe a month or two. But anything longer than that is going to come back to us as an emergency surgery, which is more painful, more costly, and it's going to take several days out of our schedule versus they can be home a couple hours after the surgery on the same day.
But even worse than, say, emergency surgery is if you wait like 5 days of inflammation, we're not going to do your surgery. It's going to be so stuck in there. It's going to be so high risk. What we do is actually have the radiologist put a drain in. That drain stays in for like 2-3 weeks. And then we will schedule you, a month, 8 weeks, sometimes later, to take the gallbladder out at that time. And most people absolutely don't want to drain. But if if you wait too long, we have no choice but to put a drain in
Right.
for safety.
Right. So hopefully our patients who are out there and listening, they can actually maybe follow our directions on this. Now, Another common general surgery is diverticulitis. Now, although it's a very difficult word to say, even for me, I know a lot about it. Is because one of my very close friends, we won't name the person, but both you and I, we know, when he was going through this, I had to do a lot of reading. So this is when it can be one of those. Many people don't know that they have it until they have some crisis. So can you explain to us what is diverticulitis, and then we'll go into a little bit more
Sure.
details.
Diverticulitis is a disease where basically, as you age, you get little outpouchings in your colon from weaknesses in the wall of the colon. And the more pressure that builds up in there, the more it pooches out. And then sometimes things can get stuck in there, poop,
Hmm.
food, and then it gets inflamed. And when it gets inflamed, those diverticuli, so it goes from diverticulosis to diverticulitis, which is inflammation of the diverticulum. The most common place for it is actually in the left side of your colon, called the sigmoid colon. The main reason why is the sigmoid colon is kind of S-shaped. And so when it's S-shaped, it builds up pressure as the stool is trying to get through there. And so that's where it kind of adds more pressure to those diverticulum. That's why it's more likely to cause inflammation and even perforation. So diverticulitis presents itself usually as pain, left lower abdomen. It usually starts out vague and then it gets worse. Oftentimes you have fevers and chills associated with it, sometimes diarrhea. And once you get it, it doesn't go away very quickly. So you need to be on antibiotics for several days, sometimes several weeks. And then once it kind of cools off, then we do a colonoscopy, usually about 6 to 8 weeks later, just to make sure that it truly is diverticulitis and not, say, a colon cancer that caused the inflammation.
Sure.
We really recommend that once you have diverticulitis and you've had it more than twice, it's time to get that part of your colon out electively to prevent further episodes of that. Because once you have diverticulitis, the chance of you having it again is about 50% or higher.
And it has a lot to do with our eating habits too.
Absolutely. Low fiber diet, lots of meat and protein basically makes you more constipated, so you have a higher risk of diverticulitis.
So, like, in the colon itself, that there are those little pockets, right? So they can get, they can actually pick up food or like whatever is
Yeah.
processed. So then they can get infected, and that's kind of like the main reason, in simple words. So like,
Yes.
remember, I'm the not licensed one in this discussion, but when I was reading this, it was so clear to me why it would be happening. So then, like having a good, flow would definitely be a good way to get rid of or prevent this to happen. And this is why, like maybe some people, they when they look for solutions on the internet, this is a little bit dicey where you can actually pick up certain eating habits, but it doesn't really actually delay the process. It's just making it more manageable. But it can be so dangerous at the same time where it can become uh, more like severe to a point where this can actually be like a game stopper. So like um, a lot of people are suffering from this, and then they can't
Yes.
even do their daily functions.
Yeah.
Like fistula is one of the things that I'm thinking about. The complications is like you don't want anyone to have that, right?
Yeah,
So
no,
it can
absolutely.
become a huge problem. So again, the best thing is when it's diagnosed early on. We want to make sure that we don't delay. Now, do you have any uh, examples of one of the delayed diverticulitis where it could have been much simpler if it was done in a timely manner?
So basically, diverticulitis, there's just like a whole bunch of different spectrums of diverticulitis. There's, uncomplicated diverticulitis, which is usually mild. It gets better with medication.
Hmm.
Um, And, sometimes it could be occurring once, sometimes it could be once every 10 years. Um, right now, we are treating a patient he's 33 years old. He had, recurrence after recurrence after recurrence, or basically just wasn't getting better with oral antibiotics. Now he has a PICC line that he went home with, and he's getting IV antibiotics until we could cool it down enough to do a colonoscopy and then take his colon out later. Um, so there's a whole bunch of different spectrums of diverticulitis. The thing is, if you have pain in your abdomen, you don't want to blow it off, right? You don't want to just say, oh, this will go away. It's just a GI bug, especially if it lasts longer than a day. You want to go see somebody or go to the emergency room because most of these things are diagnosed by CAT scan. And I had a patient that, had appendicitis for a week and said he just thought it was just a bug. And then he came in, he had perforated appendicitis, he had an abscess, and he's an older guy, and he's a diabetic. And so the more medical problems you have, the sicker you're going to be when you have some of these problems.
Right.
So you don't want to wait. You want to just get it done right away. CAT scan, it's really easy, it's painless, it gives you a diagnosis right away so that is this a surgical problem or is this something that we could treat with antibiotics?
Right. So now these like gallbladder, diverticulitis, and even for hernia, do you have certain age kind of ceiling that you wouldn't do any surgery?
No.
No.
Yeah.
Okay. So like someone like my mom, 74, like we wouldn't want her to delay if she has like any issues with gallbladder. We definitely want that to be taken care of.
Correct. I mean, obviously, we want your health to be adequate enough to withstand general anesthesia. So what we normally do is we assess your health risks, and then optimize you so that we could offer you surgery. If we don't think that we can offer you surgery because your health risk is so high, then we would try to find another alternative that doesn't require surgery. But most of these are surgical problems.
I see. Now, our last general surgery type today is appendicitis. So this is like, in medicine, a lot of things can be sexist, and I think this is one of those. It hits the men, younger men mostly. That's what we know. But when we look into this specific condition, is there any way that this can be managed without having an operation?
So there's a lot of studies that came out, in the last probably like 5 to 10 years saying that you could treat appendicitis with antibiotics. But if you ever go to American College of Surgeons meeting, they're going to tell you appendicitis is still a surgical problem, meaning the best and easiest way to take care of it is take the appendix out. Can it be managed with antibiotics? Yes. Not all the time, though. So if you have something like you ruptured your appendix and you're not sick and you kind of walled it off, what we do is we delay surgery by basically putting a drain in, treating you with antibiotics, make sure all the infection is gone, then later go on and take the appendix out. If you come into the hospital and you've had like weeks of pain and you have a little bit of inflammation in your appendix, guess what? We should just take your appendix out. There's times where we have managed appendicitis without surgery and with antibiotics because those studies say you can. And what you find is people are in the hospital longer. They bounce back with appendicitis again. And sometimes they have other problems. You mentioned fistula. Sometimes they could have a bowel obstruction. Sometimes they could have an abscess. So the best time to operate on appendicitis is when you have appendicitis and it's early and it's easy to take out. The longer you wait, the harder it is to take out, the more complex it can be. You could treat it with antibiotics to try to make it an easier surgery in the future, but in the end, you still should do surgery.
And why is this happening? Like, what's the cause of that?
Of appendicitis?
Yes, like for example, if Ethan, did you have yours? No. Okay, so I have mine. So like I didn't have procedure. So, but young men, well, included myself in the young men. So, well, for young men in their 20s, they are high risk.
Yeah.
So what causes this?
So a lot of it's just bad luck. But most of the time, what happens is this little piece of poop, we call it a fecalith, or debris will get stuck at the base of the appendix and block that off. And the appendix is kind of like a hollow organ. It's appendage off your colon. So it still has an inside, it still has a lumen. When that area gets blocked off, guess what? It's in the colon where there's lots of bacteria. The bacteria grow and it's kind of obstructed so it can't leave. And it just gets inflamed, causes bacterial overgrowth and an infection, and the appendix gets
I see.
it's inflamed.
Now, what about for pediatrics versus adult? Are there any differences between the two?
Meaning differences between the treatment of appendicitis.
Right.
You know, like back when I did my training for pediatric surgery, which was like 25, 30 years ago, everyone got their appendix out. I don't know if it's changed since then.
I see. So that they would be treated the same.
Right.
Now, this is, although it's a pretty simple procedure if it's done in the right setting, pretty straightforward. When I say simple, because it's very common, that's why I say simple. But simple for you versus simple for me are two different things. So, every time I say, like, how many gallbladders you have done in your professional life, probably is thousands, right? And it's probably so easy for you to do it, but for me to even be in the OR can be a complication. So just from everything else that you guys are doing there, so it's not simple, but it's straightforward. So, but it can become a deadly condition
Absolutely.
if it's not, act on. Like if you don't act on it right away. So this is why delaying these things is deadly in a way. And yet we still see this. Anything that you would actually suggest for our patients to maybe change this mentality so then they can actually look for these solutions earlier?
Yeah. So my suggestion would be if you have abdominal pain and it doesn't go away and it persists past the day, it's time to go get it worked up and rule out whether it's appendicitis, whether it's diverticulitis, whether it's cholecystitis. And then the other suggestion I have is if you have a painful lump anywhere, you got to see somebody to get it worked up.
So delaying is the main complication. So that's why, again, one of the reasons that we wanted to do this session and make sure that our patients really understands what's happening. What we see in healthcare is prevention, early detection, being proactive. It can make things so much easier to deal with and less complicated. So there's no exception to this. So that's why we want to make sure that our patients take advantage of these information that we put out there. Dr. Wynn, thank you so much for joining me today.
Thank you for having me.
I know a lot of people are going to benefit from this, understanding risk and real risk of the general surgery and ignoring the symptoms, what can happen. I think we did provide a good knowledge base out there. We are hoping that we would be maybe cover some of the specific topics later on in time. I know we are going to have a colorectal session with Dr. Sachin Vaid one of these days, and then we'll be back with our Bariatric Friday topics next week. Today we have some delay on our schedule. Our 2 p.m. schedule, 2 p.m. session is, I just got a message during the session, so it's going to be, most likely it's going to be at 4:30 now instead of 4. So we apologize for that delay, but we will be back with Sarah McBride at 4:30 on Friday. Well, thank you for joining us, and we'll see you soon.